Alright, so now that y'all were able to take a break, we're going to pick up where we left off with types of EMS systems. So there's multiple different EMS systems that exist within the United States. You can have EMS services that are based off out of a fire department. Um, this is available all around the country, whether it's because it's as it says, it's based out of the fire department. May or may not, they may or may not have ambulance capabilities or transport capabilities. But if you have a FDEMS service, it can be paid time, it could be staffed by part-time personnel, or it could be completely volunteer. But they're able to give emergency care for your 911 service because the nearest ambulance service may be 30 miles away. So you're reliant on that volunteer fire department to give you the help and care that you need until the EMS arrives. You can also have municipal EMS services. With municipal EMS services, usually they fall underneath a city service. They work very closely with the local fire department. Um, an example of a municipal EMS service would be Ozark EMS, Headland Fire and Rescue. They have their own EMS service. Um, only Slocum, I believe it would be is well, I believe they would be a municipal EMS service. You can also have private EMS services. These are for-profit organizations. Pilcher's Ambulance Service would be an example of it. They do still provide 911 services. They do transfers, non-emergency transfers, just like a municipal service. The only thing is the city can't doesn't set their rules and regulations. It's all done by the stakeholders or the owner of the company. You also have hospital-based EMS. This can be for-profit or non-profit, depending on how the hospital is organized. They operate just like that of a private EMS service. They may or may not provide 911 capabilities, just depending on what they're wanting to do. But they do normally do inter-facility transfers and non-emergency transport services. Opelika um, at East Alabama Medical Center, they have that would be a hospital-based EMS provider. They provide 911 and inter-facility transfer services for that local area. You can also have a law enforcement EMS service. This is just like with the fire service. Police departments are able to do help respond with medical emergencies. Um, Sometimes in smaller communities, uh, this might be more prevalent based because of how long it might take for an ambulance service to respond, but also because, you know, small community, probably not a lot of crime, so it's less burden on that officer. You also see this a lot of times with police departments that have SWAT teams or special response teams. They may have an EMS provider attached to their team as well. Within the national EMS scope of practice model, there are four levels of practitioners that we have. You have the emergency medical responder. This is your lowest level. Not trying to downplay it. You know, we're all integral parts of the team. Um, but they can go ahead and start giving that life-saving care to patients who call 911 while you might be waiting for uh, the advanced care, whether it be an EMT unit, advanced unit, or paramedic unit responding. They're able to provide basic airway care, place patients on oxygen, get vital signs, um, do basic first aid, CPR, and even provide childbirth. At the basic EMT level, they're able to do everything that an EMR can. Only now they have a bit more training as far as patient assessment. They can do a little bit more advanced oxygen therapy. more advanced vital signs, as well as they're limited on what kind of medications they can administer, but they can still administer medications. At the advanced EMT level, you're trained up to you're able to do everything a basic can, and now you're able to do a little bit more as far as advanced life support services. Um, you're able to do more advanced airways. You're able to start IVs, um, intraosseous lines, or having to drill into a bone to give medication that way. You're able to give a few more medications than you are at the basic level. And then finally, you have paramedic. At the paramedic level, you're able to do everything a basic and an advanced can do. But now you're trained in more advanced assessments and patient management skills. Paramedics are also able to perform more advanced treatments. They're able to do more aggressive airway treat methods, um, cardiac rhythm analysis, uh, needle decompressions. I mean, that, intubation, just to name a few things that a medic is able to do. Within the healthcare system, you have your hospitals, you have various treatment centers, but you also have pre-hospital care and you have out-of-hospital care. Just looking at it, you're like, well, what's the difference? You're out of the hospital. Well, there is a difference. Pre-hospital care is emergency medical care that's provided to patients before they are transported to the hospital. All right. With out-of-hospital care, this is care that's given during an inter-facility transport. All right. So pre-hospital care, you initiate care on scene and you take them to the hospital. Out-of-hospital care, it you picked them up from a facility, you're transporting them to another facility, but there's care to be done in the middle. Okay? That's the difference between the two terms. There's multiple different facilities that we can have that we can transport patients to. You can have a trauma center, burn center, psych capabilities. Um, in our local area alone, we have a trauma center. You have the medical center, Southeast Alabama Medical Center, OB Center, Flowers Enterprise, Southeast, Pediatric, Southeast Flowers, Stroke Center, we have a Southeast, Cardiac, Southeast, and Flowers. Um, Psychiatric Center, we have psych capabilities here in Dothan as well as in Ozark at Dell Medical. So knowing what your facility is capable of kind of gives you an idea of where you need to take your patient to. And some of these that we don't have around here, we may have to take somewhere else. Burn center, for example, we don't have a burn center here locally. For if we have a burn patient, we either have to take them to Mobile or we have to take them up to Birmingham. Now, if someone calls me 911, I can't take them to Birmingham from there. So I'm going to do basic care. If I have to, I'll call a helicopter or I'll take them to the nearest facility, get basic care or get them stabilized at that facility. Excuse me. And then we'll transport them out from there. This is inside of a trauma bay. As you can see, they have, a lot of equipment available. This is just a snippet of the number of people that are available. There's no a bunch of people that's standing in the background. You have lab available that is there. You have surgery there. You have radiology, respiratory therapy. Might have the neurosurgeon, cardiac thoracic surgeon, whatever is needed based off the case that's coming in. EMTs will work closely with um, paramedics as well as other services. In this picture, that you have providers from one service working with those of another. In this one, you have them working with the fire department. We're a family. We all work together. We're all going towards the same goal. If you look in your book at table 1-1, it covers some roles and responsibilities that we have as an EMT. We are responsible for maintaining our vehicle and keeping it ready. We want to make sure that we operate the vehicle safely. That's why we need to have an EVOC certification or emergency vehicle operators course. Ensuring safety. Safety is number one. That is paramount. Safety of yourself, safety of your crew, then the patient, then bystanders. You're not going to do anybody good if you get hurt while you're on scene of something. Providing care we're responsible for, even if you're a basic, if you see the medic doing something wrong, let them know. We all serve as the advocate of the patient. If they're unresponsive, we're definitely their advocate because they can't tell us what their wishes are. So we want to try to do what's best for our patient. Just name off a few more: providing emotional support to the patient, relatives, and others on scene, because you're going to deal with some very emotional calls. Definitely deceased cases. Um, you want to make sure that you maintain your own personal safety. And this picture, I can't tell, but just by looking at it, what issues do you see? That's right. You can't tell, but I don't know if that car is stabilized. There should be, if it's properly stabilized, there should be ropes. You'd have the vehicle tied down. You'd have cribbing to stabilize it. Um, I wouldn't be still working underneath the patient. I would have quickly gotten him out. That's me. We're also responsible for doing proper patient assessment and providing emergency care. We want to make sure that we identify and manage any immediate threats to life. And during doing a good secondary assessment, so that way we can make sure that any other problems that we don't find during our primary assessment, that we properly treat them. We want to make sure that we transport our patient properly to the most appropriate facility and giving them adequate help. And then ultimately contact medical control if for any medications that we give, let them know what we're bringing in, nature of illness, mechanism of injury. So that way they can just go ahead and start getting stuff together, where it be a stroke team, trauma team, surgical team, whatever it may be. And then if the patient changes anything in any way, they start deteriorating, call them back, let them know. So that way they're ready. And we want to make sure that we transfer care at the receiving facility. As you can see in this picture, the EMT is giving the doctor, they're giving him his report. They're giving a good verbal report. Okay? So we want to let them know what treatments we did. Then we're going to move the patient over to their bed, and we may still provide assistance. If we're working a code or a cardiac arrest, we may still be doing chest compressions after we move the patient over. You also want to make sure that you do good record keeping. If you didn't do it, don't chart it. But if you did it, chart it. Write it down. Because otherwise, 5 years down the road, if it gets pulled in a legal case, it didn't happen. Um, Patient advocacy. If we're dealing with a deceased person, we want to try to conceal the body of the patient. Um, try to keep as much privacy as we can. There's some professional attributes that are important that all EMS providers should have to help maximize our effectiveness. You should have integrity as a person. You should be empathetic because you shouldn't be the type of person that I'm going to have to worry about stealing something or lying or if you're going to someone who's sick, um, not being, not necessarily relating to them and not trying, completely lowering yourself, lowering your guard, but show some form of empathy. So the patient feels more comfortable with you. You should be a good patient advocate, have good teamwork, good time management. Now, these are just a few things. Should be have a good clean appearance, good personal traits. Should be able to handle the physical demands of the job, as well as maintaining your knowledge and skills. At the state, in the state, or at the, excuse me, at the state level, you have the state EMS agency. Our state office is based out of Montgomery with the Alabama Department of Public Health. They're responsible for planning and coordinating all of our activities. Um, as far as our protocols, treatment, licensure of our ambulances, um, any issues that may arise, they come down and they'll investigate them and make any judgment calls based off of it. You have a medical director not only for the state, but you also at your local level. They may give you direct oversight. Um, so, for an example of this would be uh, calling your physician, seeing what they want you to do. Okay, this would be your online medical control. You may also have indirect medical oversight. Sorry. This type of role, um, I'm trying to think of a good way to explain this one. This with this type of medical oversight, as far as the daily operations, because your medical director is not going to come down and check on you every single day. It ain't going to happen. So there's some medical oversight that your chief, your EMS captain, your supervisor, they're going to kind of keep on a more day-to-day basis. Okay? Then you may have on and offline medical direction. Online direction, you're actually calling the hospital, getting orders to give certain medications. We also have set protocols and procedures or standing orders as far as what procedures, what medications we can do that we may not necessarily have to call a hospital to get permission. Medical directors also help participate in our education. They also they're responsible for our upkeep of our skills. Sorry. So how our personnel function as far as the service, um, is set by our medical control, our medical director's guidelines. So he or she may alter what we can or cannot do based off of what he feels that our providers are capable of doing. So the state may allow us to give one medication, but our medical director may not want us to give that medication, if that helps as an example. We're also responsible for quality improvement. We're always doing checks and going back and looking at our system. How, was there any issues with any calls that we've been on? What can we do to improve? Do we need to do more training? Do we need to update our equipment? Um, do we need more personnel? Okay. This is continuous quality improvement. Not only do we do it internally within ourselves, but so for example, you may have a QI supervisor. This person, that's all they do. They go back, look at your PCRs. But this person may or may not have a bias, because I mean they're getting paid by that service. So what we'll also do is we'll send all of our stuff out to have another a unbiased provider or unbiased company to look over our PCRs or our reports and and maybe suggest other things that we may not have seen as far as what needs to be done for quality improvement. There's also issues that we may have in patient safety. There are certain aspects of our job that are very high risk, and it is on us to try to find ways to minimize these issues and to reduce the number of mistakes that are made. These are just some examples of some of the issues. You may have issues with transfer of care from one provider to another. You may forget to tell that person. Um, you may have forgot to uh, relay information, vital information that was needed for um, that patient. That'd be integral to their ultimate care. Carrying and moving patients. We deal with heavy patients. We may have patients that range from 100 pounds all the way up to 500 plus pounds. So we want to make sure that we use good body mechanics to lift and move our patients. Um, Improper skill performance, not knowing what you're doing, not having the knowledge to do what you're doing, making sure that if you're giving a medication, making sure you're using the right medication, that you're giving it at the right time, you're giving it the right way. If you have any assumptions about what could be going on, ask. Don't just guess. If you need help making a decision, use it. Whether it's calling medical control, looking in your protocols, asking about your partner, using a Broslow tape with pediatric patients. This is all stuff that'll help you reduce the chances of causing harm to your patient. As I said at the beginning, there's research being done. Is this research that the procedures, the medications, the equipment that we can use came from? All of this was done to help improve the outcome of our patients. So, when they're ready to do research, they start with an educated guess. They formulate their question. Once they ask their question, they start looking up in research. Has this ever been done before? Or, you know, how has this helped out in the past? Once they get that research, they start determining whether it's valid. Is it reliable? Is this trustworthy? Then they take it in front of a board and they start using it. And if it supports a change in practice, if it's shown to better us, we're able to provide better care, or if it improves patient outcomes, then they'll make a change in protocol. Though that's how it's done, guys. Unfortunately, that's why there's research still being done, and that's why you as a practitioner is integral to it. A lot of our stuff is either based off of military action or what was done in the hospital. And it doesn't always transfer over. So we've got to develop what works best for us. We use the same approach as everyone else as far as developing our research and our guidelines. All of this starts. Sorry, let me backtrack. So, evidence-based guidelines, as discussed in the previous section, it helps kind of make our decisions. Um, whether it's through peer review, gathering your evidence, but you create your guess, you show that it's evidence based, it's supportive, and it'll, you know, help us out as a EMS provider. They re-update the protocols, they issue the guidelines, and they implement it. Um, and then once it's implemented, they go back and they look at it again. All right, how effective is this? Is it really going to work, or did it work in the small scale, but now how is it working in the large scale? If they see that it's not working in the large scale, they may backtrack it again. All right, that's how stuff is done. We are a very large part of the public health team. As I said earlier, we're the first step in the hospital care continuum of care. But we also, because we don't always transport every single patient. We may do uh, things where we're checking vital signs. That's all we're doing. We're doing a um, now I've lost the word. Health promotion out at the local mall, where we're checking vital signs, pulses, checking blood sugars maybe. When we go to calls, we may be looking around and looking for, is there stuff that that could prevent the patient from falling. We're also checking seat belts, promoting seatbelt use and helmet use with people who ride bikes. We're keeping an eye out for diseases that may be um, arising that could be a public health issue. There's been some great strides that have been done as far as in public health that's helped out in the world. Vaccinations. A lot of people don't feel like vaccinations are helpful. I will tell you right now, I am a strong proponent, excuse me, for vaccinations. Definitely for our children. Because when they're first born, they have what's called passive immunity. So their immunity they develop is based off of stuff that they're exposed to. So if we can expose them to certain uh, viruses that they may not necessarily become infected by it, but at the very least go ahead and get their immunity built up, it prevents them from getting sick and possibly dying. Um, Reductions in deaths from coronary heart disease and stroke, promoting people taking aspirin, safer and healthier foods, um, you know, barrier devices during sex to prevent um, STDs from being uh, spread, reduction in tobacco products being used. That's why you see so many commercials on TV nowadays trying to get people to stop using tobacco because of the effects that it has on a person. In this slide, they're showing, they're out promoting health. They're doing a CPR class out in the field. They're teaching people in the event that they have cardiac arrest what to do, how to identify it, how to do CPR, even if it's just doing compressions only. Blood pressure screenings, going out checking people's blood pressure. If you see signs, if they're hypertensive, maybe referring them to a physician if they don't have one. Doing health education programs, showing people what we do, You know, this is all stuff that ties into um, promoting ourselves in the community. Um, whether it's, as you can see in this slide, showing stuff, some of the stuff that we do to the kids, to doing first aid classes for adults. Mobile integrated healthcare is something that's recently been coming out. What it is, it integrates services from a variety of healthcare entities and practices into EMS, whether it's home health care, hospice care. Um, there's even talks of possibly radiological aspect of it coming in. Um, just that way, you may have patients that are unable to get out, or we can go out to the patient. That back in the day, you had the physician come door to door. Now you have a medic coming door to door, checking on patients. You may also have a community paramedicine program. Um, with the community paramedicine program, what they do is it is provided by an EMS agency. Um, they're also integrated with other healthcare entities, so instead of the medic or the services being mobile and moving along with the EMS provider, the medic is integrated with all of them, and now the community paramedic refers these people to these entities if they need hospice care, or if they need home health care, or if they need physical therapy at home. They refer all of this to them. By being able to do this, it increases access to areas where it may not be served adequately by a physician. You have some areas where the nearest doctor may be, 3, 4 hours away, so it would be cheaper, instead of bringing a physician in, just to have a community paramedic who might be able to serve a uh, local town, or community, or even a county. They also are able to provide advice to 911 callers rather than dispatching resources. By that, what I mean is, um, so as we mentioned before, EMDs, they give basic first aid, stuff like that. Well, what a community paramedic is able to do is advise them on certain medications that you can buy over the counter. Um, say, instead of dispatching an ambulance, be like, maybe you should suggest going to a urgent care clinic but to be seen instead. Okay. If y'all have any questions, please feel free to shoot me an email. Um, I'll answer them as soon as I can. Just a quick summary of what we covered today. Just a little bit about the history of EMS services. Uh, you know, some areas that are defined by the NHTSA that we all of us should address. The 4 levels of EMS providers, our responsibilities, how medical direction and QI and quality improvement plays into the EMS system. A little bit about how we've changed over time. How about mobile integrated healthcare and community paramedicine, and how it's kind of helped shape EMS how it is today, and how it could potentially evolve into the future. If y'all have any questions, like I said, if y'all have any questions, shoot me an email. If not, I will see y'all in class.